As we have formed a quorum, please invite the witnesses to join us.
郁文，我哋而家陣間我會進入去第4部分、第5部分啦。
We are going to proceed to Part 4 and Part 5. Part 4 only. I was not at the last meeting. Part 4. Do we have a verbatim record for the previous meetings? Alan? Part 5? I think. HA? You mean issue 4? Issue 4? Part 5. Secretary, welcome. I wish you all a healthy and prosperous New Year, and I hope that we don't have to see you too often. We're now on report number 63, chapter 2, issue 4. Members may wish to ask some follow-up questions. Depending on the time available, I'll allow them to raise them. Or if not, then we can ask them to raise the questions in writing. Our lead member is again Mr. Alan Leung. Mr. Alan Leung, you go first. Every member will be given 10 minutes of time. Who would like to raise questions? Hands up, please. Any declaration from members? No. Alan? Thank you, Chairman. Today, we'll proceed to Chapter 2, Part 5 of Chapter 2, Report number 63. And this is the specialist outpatient service to elderly patients. According to the audit findings, from 2009 to 2010, or 2009-2010 to 2013-2014, in those few years, 4 years exactly, the number of elderly patients seeking treatment from specialist outpatient service, those over 65 years, has grown from 1.88 million to the 2.11 million in 2013-2014. So an increase of 230,000 in terms of the count of elderly patients. So in respect of the demand on specialist outpatient service for elderly patients, it has been on the increase. If we look at the issues from a value for money perspective, in the paragraph 5.13 of the audit report, it stated that the total expenditure is $9.9 billion. Paragraph 5.3, it stated that the total expenditure is $9.9 billion. So against this background, I have a few questions on the value for money issued. We invest about $10 billion on such service. So the question is, are we doing a good job in meeting the demand of elderly patients for specialist outpatient service? The hospital authority has said that they do not differentiate patients in accordance with their age. But if you look at 5.11, in terms of attendance, there are quite a few elderly patients attending such clinics. In the 4 years concerned, there was an increase of 12%. Last time, I gave notice that I would like to raise one particular question today. At present, there's only 8 specialties: surgery, psychiatry, orthopedics, ophthalmology, medicine, gynecology, and ENT. At one time, there was a specialty called geriatrics. So my first question is whether you'd have any breakdown in accordance with the patient's age group. And it said that SOP will be provided based on individual assessment instead of the age of the patient. So that's the official reply. In the past, we had geriatrics, and the geriatric specialty has a special logic to it. And that is the doctors are more familiar with the ways to handle the elderly patients, so they are able to provide better and holistic service to elderly patients. So if we are to revive this specialty of geriatrics on top of the existing ones, would that mean that resources are better invested and that elderly patients will get better treatment and service? Before I invite the official to reply, I believe there's some information in response to this point in Gen 4. It's page 6 of the English version under the subparagraph J. I won't repeat those points already set out in the written reply, but please elaborate your answer. Or you may wish to answer the other questions, the other issues. First of all, there's a definition, a medical definition of a specialty, and there's a multi-layered definition. If you look at specialist qualifications, there are different tiers, different layers. And if you look at this from the structural perspective on the provision of clinical services, should we organize with reference to specialties? But there are specialties we regard as a specialist service, such as urology. But in some places, you would go to the specialty you seek, urology, for example. But in some hospitals, it's a part of the specialty of medicine. But they have special clinics for urology. And in some, this specialty is taken care of by the surgery department. But of course, a specialty can be called by different names. And here, of course, when we talk about specialties of the HA, we are talking about the arrangement made by the HA in treating the patients. This is a trend that we have more and more specialties, and the division gets finer and finer. so a doctor will be more and more focused on a smaller and smaller area of specialty. But if that's done to a greater degree, then you have problems of deploying manpower. For example, if you want to rotate duties, and you need to get specialist doctors for 8 specialties if there are 8, and 16 if there are 16 specialties, and so on and so forth. Let me check for a minute for some more information. I can ask HA to supplement. The specialty of geriatrics is special in its own way, because geriatrics is not about anatomy or physiology. It's based on age, like pediatrics. The specialty of medicine has a long history. It's about clinical judgment and medicine and prescribing medicine. So it's medicine, it's the specialty of medicine. And then gradually it was found that children are special in terms of anatomy and physiological characteristics. So that's the how the specialty of pediatrics came about. And then it was later found that older patients have special problems. So although it's still within the specialty of medicine, so they created this specialty of geriatrics and take surgery as a specialty. It was a general discipline, and then gradually they have different surgery specialties for different organs. So it's a kind of evolution based on different categorizations. Elderly patients do not just go to seek geriatrics treatment. For example, if an elderly patient suffers from osteoporosis or bone fracture, then he may seek treatment from orthopedics. And some other specialties, they are now getting more and more elderly patients suffering from different diseases. So at the end of the day, when we talk about specialties, do we want to go to our finer and finer divisions? Would it be better so that medical science becomes more and more specialized, or should we look at it from the angle of doctor deployment? And since both the specialty of medicine and the specialty of geriatrics are basically about prescribing medicines, so since the approach is that of medicine, should we categorize the specialties like this so that we can deploy doctors in a better way? For urology, if you if you insist that the urology doctor should be on urology only, or if you want to have the surgical team in the hospital to have subdivisions, and then you have to provide a roster for different specialties or subspecialties, then there would be issues about manpower deployment that we need to take into account.
So, Chairman, you agree? I may defer to the HA representative, as the CEO is also a specialist in geriatrics. Well, perhaps let me say a few words, and then my colleague can supplement. And in fact, we do have a specialty in geriatrics, if you're talking about specialist doctors. With an aging population, we are coming across more and more conditions and illnesses. And now the population, 30% of the population is 65, or the elderly population will rise from 13% to 30% of the total population. So all specialists, for example, ophthalmologists, they will not need to take care of elderly patients as well. And for internal medicine, we already have specialists in the geriatrics department. We call it general medicine. Say if an elderly patient has a heart problem, then a cardiologist's help may be needed. And same as stroke, a specialist specializing in strokes will be engaged. So we have a team of surgical doctors responsible for elderly patients, and we also have a fine division of work for special diseases. And for outreach teams, we also focus on this work. So basically, for the Department of Surgery, we have professionals focusing their effort on this. And psychiatry as well, we also have specialists looking after elderly patients, and I can defer to my colleagues to say more on this. Well, I think we can discuss this issue from two different perspectives, from the division of disciplines and or classification of specialty and the organization structure. And geriatrics is a subspecialty under a specialty ever since I started to work in this profession in the 80s. And in early years, when I was giving clinical treatment to now, when I am the supervisor, I see a change in the role. This is part of an administrative decision. And also, since the demographics are changing, in early years, we have classified the specialty of geriatrics based on the age of the patients. And yet, with an aging population, and it is not desirable to have further classification for patients above the age of 65, 70, etc. And there were also problems regarding division of work. So, in the end, it was decided that both subspecialties should be subsumed under one specialty, and there should be collaboration. And then there was development, and there are outreaching services in geriatrics. And as Dr. Leung put it, for A&E cases, if the situation is acute, then it will be dealt with at the A&E. And academically, for the classification of specialty, and as far as management is concerned, there have been discussions in this regard, and there is no concrete answer. It all depends on the allocation of resources, target service users, and the organization structure. The explanation is very clear. Right, very clear, and I have really learned a lot. But I think why Chairman will understand why I'm asking this question. As we know, in about 10 years' time, 1 out of 4 in Hong Kong will be 65 years old or above. And when we talk about gender mainstreaming, we said that in the past we neglected female. There were no facilities in shopping malls for breastfeeding, and we asked whether childcare facilities could be provided at the workplace. That's the angle we have adopted. And as our local population ages, and as Dr. Au put it just now, in the 1980s, there was a department of geriatrics. So with a sharp increase or rapid aging population, isn't it time to review the situation? It's been about 20 years since, well, yes, there are still geriatrics, but my point is whether we should, it should be elderly patient based. For example, in Table 19, Table 20, for an elderly patient of 75, for example, if the elderly patient has an eye problem, then for Hong Kong West, the longest 90th percentile waiting time, according to this table, the elderly patient would need to wait for as long as 21 weeks. And for NT East, if you deduct the shortest 90th percentile from the longest, then it could take as many as 78 weeks. If you have a specialty for elderly patients who suffer from eye, bone, ear problems, and some kind of memory loss, and some kind of mental illness, then they may not need to wait for treatment to be received from 4 specialists with different waiting time. And I'm just talking about common problems suffered by elderly patients. Now, as I mentioned, poor eyesight, poor hearing, and poor memory, and some kind of mental illness, the 4 common problems, then wouldn't it be better, as far as allocation of resources is concerned, to have a combined specialty? I am speaking at the macro level, I'm asking whether it's time to review the situation so that we can put elderly patients or elderly patients can form a basis for reorganizing our specialty services. Well, Alan, your point is good in discussing the how the resources are to be allocated, and I think we can include this point in the PAC report and for the panel to follow up on the issue. Chairman, I don't think the situation is as what members think, because when we talk about geriatrics, we're talking about geriatrics under the Department of Internal Medicine or Surgery. In fact, we all along we do have a geriatrics team that is elderly patient based. But administratively speaking, we do not have a specialty of geriatrics. If an elderly patient has an eye problem, then the geriatrics team can deal with the problem. Academically speaking, this is completely different. If for eye condition, he should consult the ophthalmologist, and if there is a bone problem, he should consult the orthopedics. A geriatric specialist cannot replace these specialists. So when we talk about geriatrics, we're only talking about geriatrics under internal medicine. Yes, we hope that one day we can have elderly hospitals specializing in elderly conditions. Well, medically speaking, I can't see the rationale at this stage, because on the classification of specialty, well, these are different specialties. Although for an ophthalmologist, much of his work may have to do with elderly patients, but it is not the same as a geriatrics team's knowledge. Now, my point is this. I understand the Secretary's explanation. Poor eyesight, poor hearing, bone aches, and mental illness. I agree that the patient suffering from these 4 conditions should consult 4 specialists. But in the face of a rapidly aging population, my point is whether there could be a one-stop service, a dedicated team specializing in elderly patients who could communicate with elderly patients so that referrals could be made. The waiting time can be rationalized. Now, you explained very clearly about classification of specialties. But elderly patients as target users, service users of hospital authority, should be able to receive better care, or they should be assisted in receiving your service. Well, part of your argument is sound, but I want to point out that there is a geriatrics team subsumed under internal medicine, and as you put it, the team is very familiar with elderly patients, and they think from elderly patients' perspective. For example, they have elderly daycare services available and also outreach teams, and this is the responsibility of the geriatrics team. So, in fact, even at present, we can provide the services you talked about, but apart from common conditions for elderly patients, there are other acute conditions such as heart problems. It may be better if the case is taken up by one department or one specialty instead of having to refer the case to other departments or specialties. So there are pros and cons. As for future development, well, I agree that, as Mr. Eleanor put it, that we should bear this in mind when we have future reviews. But we should also consider whether this is indeed beneficial, or whether more problems will arise. Mr. Raymond Wong, Chairman, last time, at the last public hearing about long-term care for the elderly, I was not present, and I prepared a list of questions in writing for the administration to respond. And we're now on Part 5, HA's provision of specialist outpatient service to elderly patients. Now, Mr. Eleanor started by talking about geriatrics, and we have 3 doctors here, and 4 doctors, in fact, and also the permanent secretary of the policy bureau, and we talk about policy and financial matters with you. And anyway, we have 4 specialists here, and this classification of specialty is really unfamiliar to us. We're talking about value for money, and you're giving us a lecture on the classification of specialties, etc. I think in future, when we have the opportunity, we can learn more from Dr. Ko and other specialists. However, for this audit report, this is about value for money audit. This is about money. Apart from conducting the value for money audit, they also direct us to policy issues. And the duty of electrical member is to ask questions. Sometimes the questions may not be very polite. Like myself, I ask silly questions, and sometimes you ask questions that may not sound intelligent. So in fact, I trust you because I don't know anything. Well, honestly, I don't necessarily have to trust you, but I do. Some doctors also act quite peculiarly. But this is about the HA services for the elderly patient, and is far from sufficient.
I have been very concerned about service to elderly patients. We don't have sufficient health centers for the elderly, and there's a long waiting list for specialist outpatient service. We need to resolve the problems, and HA is responsible for this. You have to review the provision of a specialist outpatient service. You should reply to all the questions raised by the Audit Commission Secretary. I don't call you doctor because we're talking about policies. Among all the specialties, 5.9 is observed by the audit that the waiting time had increased. If you look at manpower, equipment, operations, and so on and so forth, in respect of the waiting time of the different specialties, gynecology, the ENT medicine, orthopedics, and so on and so forth, do you have a manpower shortage? Do you have a especially hard time in meeting the needs of elderly patients? So it's in paragraph 5.9. There's the waiting time for ENT, gynecology, medicine, orthopedics, and traumatology and psychology had increased. Medical students would go for different specialties. So the HA would know that in the near future there are fewer new entrance to these specialties, and therefore the waiting time cannot be improved. Will the HA come up with targeted solutions? I'll defer to Dr. Leung. As observed by the Audit Commission, the waiting time for certain specialties had increased. For example, the orthopedics, there are many elderly patients, and there's also the question of supply and demand. If take, for example, gynecology, the waiting time has increased because of the need for artificial fertilization, artificial IVF services, or assisted childbirth. We have a vacancy, a total number of 300 odd vacancies. With more medical students graduating, we can certainly see some improvement, but we are not going to wait. We have come up with some measures such as special OT allowance, and we have used family doctors to do certain triage service. For example, if a patient is suffering from back pain, he may not necessarily need a specialist orthopedics service. And of course, we will prioritize urgent cases first. Can you be more specific? Audit has made certain recommendations. Of course, you are going to accept them. You are going to carry out a review. I want more specific responses, because Audit has mentioned these specialties. You talk about manpower problem. Well, where do the problems lie? Doctors or nurses or what? How can you make up for the shortfall? When can you do this? Well, in 2014, 2015, say, for example, in Kowloon East, in relation to the orthopedics specialists, outpatient clinics, we're going to spend $14 million to provide more operation sessions in the NT West. The waiting time for urology specialist service has increased. We are going to operate more operating theaters, and we are going to spend additionally $11 million to get more doctors in Kowloon West. We are going to spend money, $11 million for specialist outpatient service in We have increased a provision of 3 million off for Our Lady Mary Lord Hospital to strengthen orthopedics. So that's what we are going to do in 2014-2015. We haven't got a budget for 2015-2016, but we are going to look at specialties with longer waiting times and come up with specific suggestions and proposals. For example, Kowloon East, Kowloon West, we are going to implement certain proposals. When the budget is announced, we will be able to tell you more details. Chairman, in 5.8, paragraph 5.8, the HA has taken measures to shorten the waiting time, and there are a number of them, but we want to get something more specific. And have you reviewed the effectiveness of these measures? That's important. And if there's a shortfall, you should strengthen the provision of service. The so-called measures in paragraph 5.8 are too weak. And people have been talking about that we are having an aging population, and elderly people live longer and longer. Well, this is just a known fact. You have all the data. You know which specialties are patronized by elderly patients. For example, urology. Well, elderly people tend to have prostate problems. Those who cannot afford to go to the private sector will have to go to seek help from HA. These problems will have both physical and emotional consequences. And sometimes things are intertwined. And if you do better in one matter, you would lessen the problem faced by another. If you do not do a good job with your health centers, then HA would suffer from a heavier workload. You don't have a specific policy to tackle the issues of aging population. The problem lies in not having specific measures to tackle the issues identified by audit. The HA should come up with policies to meet actual demand. In 5.10, it said that for different clusters, the waiting time differs a lot. This is a worthwhile subject to explore under the value for money audit. If there are inter-cluster support, things would be better. The disparity can be 68 weeks for ENT. Why is it that the disparity is so big among clusters? Different clusters have different capacities. Of course, there will be some disparity. But the disparity should not be so large as to have fall foul of the value for money principle. I don't know how many referrals are made among clusters. I believe there are some. So who are doing this administrative work? Or is it does it fall to individual doctors? I would like to know if there's any solution for the big disparity in waiting time for different clusters. Mr. Wong wants you to answer the questions in respect of what you have done in 2013-2014 and what you are going to do in 2014 and 15. We need to get the information for our report. Let me first of all say something about the background to the disparity in waiting time. The hospitals were set up before we had clusters. Many years ago, it was QEH and QMH, and then we started to build hospitals in NT, and then we started to provide specialty services. So NT was a latecomer, so they suffer from a lack of sufficient specialists. So starting from 2012, we implemented the referral system. For example, for ENT, QEH has been offering help to Kowloon East cluster. We have figures on referral. There are 33,000 patients who have been referred to another cluster in order to shorten the waiting time. Of course, that's not enough. Why is it that in some clusters the waiting time is longer? First, it's a legacy problem. There are fewer specialist doctors. And second, some clinics are smaller. So even if you increase the number of doctors, you cannot set up more consultation rooms. We have been given money to redevelop some hospitals. Look at Character Medical Center. The clinics are much better than what they used to be. There are more consultation rooms for specialist outpatient service, and that's certainly helpful in shortening the waiting time. We're doing something across clusters, but some elderly patients do not want to go to a clinic in another cluster. For example, those suffering from cataract, and the patient may be suffering from other conditions. They do not want to go to another cluster because of the consideration of other services. We would like to even out the waiting time through improvement of service. We expect improvement can be achieved. So we're talking about manpower, equipment, and facilities. And all of those require funding. Can you be more efficient in making referrals? For example, elderly patients may be reluctant to go to a cluster that is far away, but some may be willing to go for it. In my constituencies, I offered eye examination service for elderly patients, and eye examination is a fee charging service. And among the affluent economies, only Hong Kong is providing the teeth examination and extraction instead of total dental care. And some elderly patients have problems with chewing peanuts because of teeth problems. This is pathetic. Hong Kong elderly people are pathetic. I recently went to Canada to visit some friends. An elderly patient told me that he received medical treatments costing the Canadian government more than $1 million. And then he got different prescriptions if the previous prescription proves to be effective. So that's why so many people want to emigrate to Canada. Yes, you are subject to certain constraints, but certainly you can do things better, in a better way, subject to the constraints. 5.11, well, I've spent more than 16 minutes. I must be quick.
Well, there were 12 geriatric SOPCs in the 7 clusters of the HA. What about the service capacity? Say, for example, with the existing manpower strength, how many cases do you deal with per week? And with the increasing trend, you must step up service capacity. You must have all the information, and we are the ignorant ones. We can only rely on the information available online, and we need to ask use silly questions like classification of specialties. Anyway, please tell us, in the coming years, what is your target? How many more clinics will there be? Of course, you've told us in the beginning that the HA do not classify cases according to the age of patients, but the reality is that the wait for SOPC services is getting longer and longer. So on resource allocation, you need to target elderly patients, as the trend is that we have an aging population. So tell us the target in the coming few years. How many more clinics will there be? How much will the manpower be increased to cope with the trend of an aging population? But what about the 12 geriatric SOPCs, service capacity, and the healthcare manpower? Dr. Leung, if you don't have information today, you may choose not to answer and give us a response in writing later. Dr. Au, we can give you the figures after the meeting, but generally speaking, we are tackling the problem. We have data coming from different clusters, and for geriatric SOPCs, generally, elderly patients can receive treatment at the Department of Internal Medicine. So not all elderly patients were under geriatric SOPCs. And also, we need to consider the focus of services for the elderly in the future. For example, for ophthalmologists, we have improved our services a lot for cataract operations, for example. For orthopedics, many cases involve pains and aches, and we are, as we conduct the review, we will not focus on any particular cluster, but rather we consider how we can design a workflow to meet the needs of elderly patients. And this is also in response to Ms. Ellen Leung's comment that it is the international trend to use elderly patients as the basis of our service design. Next, Ellen, I still have a number of questions. Kenneth, you just wait. This will be brief. In 5.16, for QMH, the waiting time is 103 weeks. For Princess Margaret Hospital, it's 78 weeks waiting time. So different waiting time for different hospitals. I want to know whether there a lot of administrative work is involved in cross-cluster or cross-hospital referral. And also for Caritas Medical Clinic CMC, they only keep certain information, but not information concerning cancellation of appointments and the appointment slots released due to cancelled appointments. Who can take this question? Dr. Leung. I think this is a very good observation in the audit report, and there are booked cases, and sometimes when the appointments are cancelled, the appointment slots can be released, and so that we can take up more cases. Now, in the audit report, there are some routine cases that are non-urgent, and they are put to the back of the list, and in fact they can be advanced. We hope that in 2015-16 there will be a coordinator for each hospital cluster, because we only have several coordinators in several clusters at the moment, so that the SOPC services can be better coordinated. And in the coming few months, there'll be a guidelines on the booking for SOPC services. So much from me, Chairman. Dr. Leung, please give us a written reply for our report. Next, Kenneth. Now, Mr. Raymond Wong, you talked about the Canada model, but the tax rates are much higher than Hong Kong. But still, it's better than us. We should increase profits tax and charge our rich people more. Kenneth Leung. Now, to pick up on Mr. Raymond Wong's question, the medium to long-term solution is to increase manpower, to give more space for more clinics and increase facilities, but it will take 3 to 5 or 7 years. And in the report about the cross-cluster referral arrangement, starting from page 71, I think things are not very clear. First of all, let's refer to table 23 about cross-cluster referral arrangement. At the moment, we have ENT, gynecology, and ophthalmology. These 3 specialties that are under the cross-cluster referral arrangement, and that's in the footnote of table 23. And the arrangement have been implemented for the 3 specialties for 24, 14, and 8 months, respectively. However, we see that most elderly patients visited the specialty of surgery, psychiatry, and internal medicine. And I think the waiting time for these cases will not be too long, because this is just common sense, and this is just my conjecture. But the question is, why had you implemented the cross-cluster referral arrangement for ENT, gynecology, and ophthalmology first? And also, in the report para 5.35, you said that you would consider extending the cross-cluster referral arrangement to more specialties. Why do you still need to consider, and when are you going to extend it, and how? Dr. Leung. For cross-cluster referrals, we started discussing the arrangement with different frontline specialists, and they have expressed their concerns. For acute conditions, they may the patients may need surgery, and if there is a long list at a certain hospital, then the surgery department may not be able to deal with acute cases. However, I think we should instill a stronger concept of patients visiting clinics in their own cluster. And in NT West and Kowloon East, with the government's subsidy in redevelopment projects and expansion projects, we hope to increase service capacity. While discussing with our colleagues, they also would like to increase service capacity. And you made a very good point just now. We hope to extend the arrangement to more specialties. Dr. Ao. Well, on choosing these specialties for implementation of the referral arrangement first, our consideration was that, for example, for ENT and ophthalmology, there was a wide discrepancy, because we are talking about routine, non-urgent cases. For cataract and ENT conditions, it is not desirable to wait for a long time, even if these cases are non-urgent. That is why we implemented the arrangement for ENT first, so that referral can be made. For orthopedics, we encountered some problems. For NT West, we have a lot of elderly patients with bone problems, and yet we failed to persuade them to be referred to another cluster, because, for example, for NT West, the patients may have more confidence in the specialists in the cluster in carrying out surgeries. Kenneth. In fact, I want to know the actual operation when a patient's case is referred to another cluster. Well, if we have an online system allowing one to check the waiting time or the waiting situation at a particular clinic or department, then the treating doctor and the patient could be given a full picture. And yet, despite technological advancements, you're still talking about managing bookings manually by a coordinator. We should have real-time information. I think this is feasible because we're talking about 7 specialties or clusters. There should be a real-time queuing system. My question is whether this is possible. Say if a patient wants to go to another cluster, what has he have to do that? How complex is the procedure? Or can the patient be referred across clusters midway of consultation? Well, in fact, we have already announced online the waiting time for 5 specialties out of the 8, such as EMT, ophthalmology, etc. My question is is the information regarding all the specialties in the 8 clusters announced? We don't have too fine division, but about what you said, technologically this is feasible, but the triage is not possible because we need a professional or a nurse to categorize the cases. Well, for example, if one suffers from back pain, it could be a sprain or it could be cancer or some neurological problems. So we need to conduct an assessment first as to whether guidelines can be issued or whether there are clinical pathways available. For that, we'll see. But for the doctor making the referral, we will further study whether it is possible for this to be made available on the network. As for announcement of waiting time online, we're already doing that. Now, when an elderly patient visits a specialist, can the patient discuss with the doctor? Say, for example, in this cluster, you have to wait for 40 weeks. In the other cluster, you just have to wait for 20 weeks. So can the patient know at that consultation session whether the waiting time is realistic, whether slots are available, whether the doctor can tell the patient at the time, instead of asking the patient to go home first, wait for a few weeks, and to ask whether cross-cluster referrals could be made. With the help of technology, the doctor can check real time during that consultation session in just a few minutes' time whether a small operation can be done across the cluster instead of asking the patient to wait at home. So my question is whether there is any centralized coordination for cross-cluster referrals, or whether the doctor or the patient has to ring every cluster and try. It is quite meaningless to announce the information online if you don't have a centralized coordination system. For example, you can have a booking system, and the person there could be doctors, and we could then tell the doctor of the situation. Well, this may not be possible now, but if doctor sees a patient and the patient has to wait, go home and wait, and then next time he comes back, the doctor tells the patient that he has to wait for 60 weeks. My question is whether this is possible. Well, explain to us your existing practice so that we know better from the perspective of resources.
Well, the member is just making a suggestion. Well, your suggestion works from a logical point of view, but it may be something risky from a clinical perspective. you can, under the trial system, you have to see a doctor before a decision is made whether surgery is required. I'll ask Dr. Au to explain further. Do you have any offer that we can make, saying that the waiting time is shorter in another cluster? Dr. Chu? Well, let me explain the triage system. The patient would be referred to us, say ENT Union Hospital, by a private doctor. The longest waiting time is 100%, 100 weeks, and another one, QEH, 18 weeks. So our colleague would take a look at the referral letter. Well, it's not an urgent case. If it's a general case, then the patient will offer a choice. He will be told that the waiting time for in QEH is under 20 weeks. Are you willing to go there? If it's yes, then at the Kowloon East Cluster office, an appointment slip will be printed for the patient so that he can go to QEH. So within 20 weeks, he will go to QEH for consultation. There's no need for the patient to go to QEH first. What if the patient initiate a cross-cluster referral? In this report, in this audit report, the Audit Commission has mentioned that in some hospitals, they did not explain things clearly, and we have accepted the recommendation of the audit, and we are going to come up with clearer guidelines this year. If the clinical conditions allowed, and if the capacity allows, we'll give the patient another slot. Table 23 now. For those benefited by the referral system under ENT, 3,000 odd, 600 of them elderly patients. Why is it that for gynecology and ophthalmology it's different? Maybe the patient has mobility problems. They don't want to go to the patient doesn't want to go to another cluster. So you've expanded resources on these specialties, but relatively speaking, fewer gynecology patient or ophthalmology patient were benefited. Can you explain why there are fewer beneficiaries under the cross-cluster referral arrangement for gynecology and ophthalmology? They've explained what the queue is about. If the female patient requires IVF, and it's not urgent, and even if you go to another cluster, it's just for a first consultation. The procedure will not be carried out immediately. We'll tell the patient that this can be done under the cross-cluster referral. But of course, a lot depends on the wishes of the patient. Dr. Au, are we talking about elderly patients here? For gynecology, basically we're not talking about elderly patients. I was a former head of an eye hospital for ophthalmology. Sometimes the elderly patient trusts the medical team after doing some examination there. The queue is long. The eye hospital has a long queue. But still some patients want to go to the eye hospital because they believe the service is better there. So the choice of the patient is not just about the waiting time. If we centralize everything, the patient's autonomy will be reduced. But since this is a pilot arrangement, I believe that we should take another look after 2 years of operation to see whether it's worth the additional resources. There are 7 specialties, and you chose gynecology as one of the 3, and not many elderly patients would benefit from this specialty. You should have considered this in choosing the specialties. For example, orthopedics and surgery. You shouldn't choose gynecology. For ophthalmology, there's a question of trust. So the reaction from the patients could well be predicted. So why did you choose these specialties? I think I should elaborate. In making the cross-cluster referral for gynecology, we are not going after numbers. We're talking about people suffering from infertility, and the disparity of waiting time among different clusters was great. Is a serious case. So from the very beginning, the arrangement for gynecology was not about increasing the numbers or reducing the time. For orthopedics and surgery, the disparity of waiting time among clusters was not big to start with. Thank you for your explanation, but here in the report we only see the figures. So you should offer explanations so that we can gain a better understanding of the case. Because LegCo will look at the issues based on value for money audit. Chairman, the HA has referred to orthopedics. How long would it take for you to carry out a review before you decide on whether you are going to do cross-cluster referrals for this? Maybe under 5.35. In respect of 5.35, the recommendations, they should give us a timetable. We know that the waiting time for orthopedic service is long. In some clusters, the waiting time is 80-odd weeks in one cluster and 90-odd in another cluster. Cross-cluster referral for these patients will be meaningless. We just want to reduce the waiting time from 90 to 80 in that particular cluster. We are going to devote more resources to different clusters. There will be a better arrangement instead of doing cross-cluster referrals. Unlike ENT, the disparity among clusters is not as big. I have nothing further to ask. Well, you have accepted all the audit's recommendations, but actually you have a different view. You should have explained the situation to the audit, and the audit would have set it out in the report. Very often government departments would accept every recommendation in the hope that we will not look into those issues. I hope in the future you offer more explanations to the audit. The report is more about figures, but you have another perspective, that is the people perspective. So perhaps you should offer elaborations and explanations in the first instance. We are on part 5. Mr. Ng Liang Sing, if you want to ask questions about parts 1 to 4, you may wish to do so in writing. Well, I was in another meeting. So I will be asking questions on part 5 now. 5.13, 5.14, in respect that of Audit's recommendations, and there's a response from the HA. It said that the CE of HA agrees in principle with the Audit recommendations. He also said that HA has been striving to shorten the waiting time for routine cases subject to manpower availability, and will continue to monitor the overall waiting time. So I have a simple question for this part. You know, elderly patients suffer from more medical conditions. I don't know whether this is agreeable to the doctors from the medical perspective. So when people get older, the chances are they need more medical service. So here you talk about routine cases. So they are not urgent. But since they are elderly patients, they are bound to have certain medical problems. And if you provide timely service, the patient will be assured, and he or she will be suffering less from pain. So that's why waiting time is important. On the question of waiting time, if we shorten the waiting time for, say, 1 day, how much more do we have to invest? Because we are talking about resources for this part and other parts that I'm going to raise questions on. For routine case, not a specialist case, if we want to reduce the waiting time for 1 day, how much in terms of resources is going to be required? And how many elderly patients belong to this category of routine cases? How much is required if we want to shorten the waiting time of these elderly patients by 1 day? And how much is required if you are asked to offer something more reasonable in terms of waiting time to elderly patients? Well, in 5.13, you have sort of vaguely agreed to accept the recommendations. But if you are you're asked to offer a timetable, if you want to achieve a more ideal situation, how much is required? Answer this question if you can. If not, perhaps you can do so later. Actually, I've answered this question previously. To tackle the waiting time of different specialties, we need to adopt different measures. The chairman has asked me to give you the committee a report. We have been asked to look at the situation. We have figures on the number of consultation sessions additionally provided in 2014 to 2015, and how much more money will be spent on the additional service. But if you look at the value of each slot, but my question is not about specialist service. I'm talking about general outpatient clinic. The patient is just suffering from some ailment. Can you shorten the waiting time?
Well, normally we also would like to promote the concept of family doctors. This is the government's policy. So if a family doctor is of the view that specialist treatment is necessary, then a referral can be made, and otherwise it will be there will be a great burden. So on general or outpatient clinic or family doctors as primary care, we should promote this concept first. If one visits a cardiologist straight away because of chest chest pain, that without referral by a GP, it may be delayed even longer. It may not have to do with the heart. Several weeks ago, we talked about that a patient waited for as long as 9 months before seeing a doctor. So please give us a response on the SOPCs 5.13. Thank you, Chairman, and he has supplemented answer. And then I want to ask a further question. You need to keep statistics to strive to shorten the waiting time. As for 5.14b, you said that you will review the disparity of waiting time in different clusters and will extend the cross-cluster referral arrangement in appropriate clinical context. What I want to say is this. In appropriate clinical context, what does it mean? And for cross-cluster referral arrangement, will transportation be arranged, or will the patient be left to arrange for transport himself, and you only arrange for doctors in another cluster? Dr. Lai, Dr. Au. Now, for cross-cluster referral arrangement, we are talking about a review of the disparity of waiting time in different clusters. This is a dynamic observation. That is, at one time, there could be a big disparity between different clusters, but a year on, the disparity may be lessened, and to tackle the problem, instead of relying on cross-cluster referral arrangement, we need a proper allocation of resources. And about this arrangement, direct bookings can be made at one cluster, but the patient will need to arrange for transportation himself. We have some constraints because we cannot ask every elderly patient to take non-urgent hospital transport to go all the way to another cluster. So that means the patient will need to arrange for transport if he has to go to another cluster. Yes. So about inappropriate clinical context. Well, I quoted the example just now. For orthopedics, as the disparity is has lessened recently, we're not proposing to implement this for orthopedics. As for other specialties, the waiting time is being shortened. On the whole, the problem is not severe. We will consider psychiatry, but we need to check the statistics first, because for psychiatry, we have subspecialties and the condition may be complicated. Now, for 5.24, Chairman, I'd like to talk about the CGATs, Community Geriatric Assessment Teams. Has anyone asked questions on that? For 5.52, as at the 31st of March 2014, there were 13 Community Geriatric Assessment Teams, CGATs, providing service to 71 or 638 of the 715 licensed RCGs in Hong Kong. And yet there were some 4,500 elderly residing in the remaining 77 RCHEs who did not receive CGAT's service. And in the next paragraph, according to the HA, a working group conducts ongoing review to address service and operational issues. Now, my question is this. The working group was set up in 1994, and in 2014, we're talking about 20 years later, and still, some 4,500 elderly people do not have access to the service, and you're still conducting a review. And then in paragraph 5.26, You mentioned that in 2012, the working group completed a review. Although the data as at the 31st of March 2014, some 4,500 elderly still did not receive the CGAT service. Well, the review was completed in 2012. I'd like to know why, despite the review, subsequently the problem under review by the working group had left unresolved. Well, let me briefly explain the situation. There were some difficulties. For the CGATs, or geriatric outreaching teams, the teams were established after year 2000, and at its peak, 90% of the RCHEs were served. Now the figure is standing at 89%, and there are new RCHEs. Although we're covering so many RCHEs, there continues to be new RCHEs. As for the review conducted in 2012, I also took part in it. We took a holistic approach and focus on the resources needed for a full coverage of the RCHEs in Hong Kong. At that time, in terms of supply of doctors, the manpower situation was not very tight, and with tight manpower supply, we need to strike a balance between A&E, clinical services, hospital wards, etc. So we made a conscious decision against the backdrop of tight manpower to not to increase manpower for CGATs. Of course, the situation is not very desirable, but we can only further expand the coverage when manpower permits. Now, earlier I asked a question, and that's about the end of this paragraph. I think, Chairman, you can give this conclusion as well. The working group concluded that when resources were available through the HA's annual planning mechanism, the CGATs would adopt a set of criteria for prioritizing new RCHEs to be covered. It's like the Pope is Catholic. If you have no money, you cannot do anything. So we could but accept it. However, do you have a clear timetable or how you're going to strive for more resources? Instead of saying when resources were available, you're going to adopt a set of criteria. You have a work plan for the Policy Bureau so that before the budget is announced, you can strive for more resources year by year to resolve the problem of healthcare service to elderly patients and meet your target. We have an annual planning or annual plan, and it has to do with manpower. Even with government's funding, we don't have manpower to expand our service capacity. We need manpower for SOPCs, CGATs, and in winter, even for internal medicine wards, it's very crowded, and we need resources for that as well. It's not easy to prioritize our resources for any area. We'll try to do more with increase in manpower. But we don't have many doctors or nurses. 3 or 4 doctors and 12 nurses. It seems that the CGATs could expand its coverage very easily. But we have tight manpower for other areas such as hospital wards as well, and we agree that when the manpower situation has eased, we will strive to do more. So it all comes down to manpower. We're not asking you to anything. In fact, do tell us what the problem is, and we'll put it in the report. Now, on this point, I have a sensitive question for the Secretary, because in your profession, some members of your profession, whom I'm familiar with, have told me that there is a sentiment of protectionism, and that foreign doctors are not welcome, leading to the fact that you don't have sufficient doctors, because foreign doctors are not welcome to participate in the profession. Is it the case? Well, we are not supposed to ask questions on policy issues. So see if it's possible to answer this question. We don't want to interfere with the policy. Well, let me give a general comment. For Hong Kong in general, we need more doctors, but mostly the HA is in severe shortage of doctors. So what we are doing is to recruit more part-time doctors from the private sector, and to retain doctors within HA to minimize wastage. And recently, we have also been recruiting retired doctors to work for us. And for serving doctors, if they are willing to work extra hours, we do offer extra allowance for them to work outside their official working hours. As for manpower, we also discussed with the Medical Council on ways to facilitate more foreign doctors to practice in Hong Kong through examination. And we also explored the idea of whether the one-year internship requirement after passing the exam can be shortened. And we try to attract doctors to practice, or foreign doctors to practice in Hong Kong through limited registration. Well, Chairman, I think we're approaching the end of the hearing. There might be a few loose ends to be tied. We may need to address some problems for the record. Well, as for the specialty with the largest number of elderly patients, definitely is the internal medicine. And geriatrics is one of the specialties under internal medicine. In fact, if you refer to chart number 3, you can see that in 2013-14, for the specialty with the largest elderly attendance is internal medicine, over 1 million, the part in green. So if an elderly patient feels unwell and yet he doesn't know which specialty to go to, then he would visit the internal medicine department first. And there are geriatric specialists within the internal medicine specialty, and this would make internal medicine as the first line of service for the elderly. So I wonder if you can step up your service for elderly patients within the internal medicine specialty by way of making manpower arrangements so on and so forth, so that when elderly patients visit the first stop, namely the internal medicine, they can get the best advice on where to get a referral, where to queue up. I wonder if this is better. Instead of, or before we have a formal specialty of geriatrics, as a policy bureau, I wonder if you will consider it from the value for money perspective.
This is to make sure that the resources used on elderly patients will be utilized more effectively. Well, whether we're talking about medicine or geriatrics, they are all specialties to the HA. You cannot just knock on the door of a GOPC. You have to be referred by a doctor, a private doctor or an HA doctor. And therefore, what you have said will not happen, that the elderly patient will not be in the position of not knowing where to go, because the doctor, whether the HA doctor or the private medical practitioner, will make a judgment. That is, apart from seeing the doctor himself, should these elderly patients be referred to a specialty in the HA, that will be the decision, the judgment made by the doctor. So the doctor, in making the referral, would make the best choice for the patient, and then the patient would get a referral slip, and he would go to the HA, and then HA, the GIS system, would apply. They would take a look at this elderly patient being referred by the doctor, whether it's an urgent, is it a serious case? If it's a serious and urgent case, then they would get an earlier the patient would get an earlier spot. Otherwise, it would get a slot as a routine case. So maybe, well, actually, under our system, the triage will be applied to the patient automatically. Secretary, is it possible that you can adopt the point of view of the elderly patients, or we can do something to take care of the emotional needs of the elderly patient by improving geriatrics under medicine? Maybe under the specialty of medicine, we can enhance training so that we understand more the emotional needs, physical needs and emotional needs of the elderly patient. So when an elderly patient goes to a medicine specialty clinic, whether the doctor seeing the patient is actually a quote-unquote geriatric specialist, the doctor will be able to understand the needs of the elderly patient better. I hope, I certainly agree that they should adopt this additional perspective in their service. I've been asked to give a live interview by a radio program. So can I ask for shorter